Welcome back, everyone, to Decode Healthcare with Harshal. I'm your lead instructor, and today we are hitting a massive milestone, Part 110 of our IPDRG Masterclass. Coming off our Part 109 recap, where we covered the medical side of MDC-17, myeloproliferative diseases, and poorly differentiated neoplasms, we are now completely unpacking the financial anatomy of a claim on the surgical side. We're going to look at the exact gears turning behind the scenes of inpatient healthcare finance, particularly for complex oncology cases. And hey, before we dive in, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. All right, let's get into it. Here is our roadmap for today. We'll be decoding the MS-DRG system, comparing medical versus surgical partitions, looking at the sheer power of CCs and MCCs, breaking down ICD-10 PCS root operations, specifically excision, resection, and extraction, and finally wrapping up with clinical documentation improvement. So let's kick things off with Section 1, Decoding the MS-DRG system. At its core, a diagnosis-related group, or DRG, is essentially a giant formula. It takes the very real, very complex clinical realities of patient care and translates them into a specific reimbursement amount under Medicare's inpatient prospective payment system. Basically, it's the mechanism that ensures hospitals are paid accurately based on the severity of the patients they treat and the resources those patients actually consume. Now, you might be wondering, how does a patient actually get sorted into one of these groups? Well, the MS-DRG grouper is a logic engine that follows a very specific three-step pathway. First up, the principal diagnosis assigns the case to one of 25 major diagnostic categories. Next, it looks at whether a surgical procedure occurred, and finally, it adjusts for severity based on secondary diagnoses. Put simply, clinical similarity plus resource similarity equals one single payment group. Moving right along to Section 2, medical versus surgical partitions. This split right here, it is incredibly impactful. The rule is strict. If a procedure is performed that meets the CMS definition of a major operating room procedure, that procedure completely overrides the medical logic. It literally doesn't matter what the primary medical diagnosis was. That OR procedure grabs the steering wheel and drives the case straight into a surgical DRG assignment. And as you might guess, surgical DRGs typically carry a higher relative weight. Section 3. The power of CC/MCCs. Almost every single MS-DRG is broken into a triplet structure based on secondary diagnoses. Think of it like a tier system. If you have just one diagnosis flagged as an MCC, that's a major complication and comorbidity, boom, it bumps the case to the highest payment tier. A standard CC gets you the middle tier. This right here proves how a single, precisely documented secondary diagnosis can drastically alter the financial weight of a case. Let's look at some of those heavy hitters. High-impact MCC conditions, things like sepsis, septic shock, acute respiratory failure, or diabetic ketoacidosis. These represent incredibly significant diagnoses. When a patient, say an oncology patient with a compromised immune system, develops one of these, it requires a massive increase in hospital resources, intense monitoring, and a much longer length of stay. Capturing these accurately, it's absolutely non-negotiable for proper reimbursement. Let's pivot slightly for Section 4. ICD-10 PCS root operations. Here is where things get really microscopic. Unlike diagnostic coding, accurate procedural coding in ICD-10 PCS demands incredible granular precision from the physician's documentation. You literally cannot just write surgery and call it a day. The coder needs the exact anatomical site, the specific surgical approach, like open versus percutaneous, the device used, and the precise method. Without this level of clarity, a coder's hands are completely tied. This brings us perfectly into Section 5, excision, resection, and extraction. This is a classic trap where doctors and coders speak completely different languages. In standard medical speak, a surgeon might say they excised an entire lymph node chain. But in the strict literal world of ICD-10 PCS coding, excision means cutting out only a portion of a body part. If you cut out the entire thing, like that whole lymph node chain for a lymphoma staging, the correct root operation is actually resection. Mixing these up can completely derail your DRG assignment. So, selecting the precise root operation requires knowing the exact scope of the surgery. Did the procedure involve taking out an entire organ, like a total mastectomy? That's a resection. Or was it just a small diagnostic subdivision, like taking a single lymph node biopsy or a liver biopsy? That's an excision. And what if you were pulling or stripping out tissue using force? Well, then you're looking at an extraction. Let's look at a super relevant example for our hematology discussions: bone marrow aspirations. You might intuitively assume these are excisions because, well, you're taking a tissue sample, but actually they are not. Because of the sheer force used to pull that marrow out, they are coded with the root operation extraction, combined with a diagnostic qualifier. It's fascinating how literal the coding system is. In fact, even the physical mechanism of the needle you use completely changes the root operation pathway. A core needle biopsy uses a larger bore needle that physically cuts a core of tissue, so that routes to excision. But a fine needle aspiration, that essentially vacuums or aspirates the tissue out, so it routes to extraction or drainage. The microscopic details absolutely dictate the code, no exceptions. Finally, we arrive at Section 6, Clinical Documentation Improvement, or CDI. Documentation is literally the lifeblood of this entire system. Poor documentation, like jotting down a vague chest pain with zero linkage to its underlying cause, gives coders absolutely nothing to work with. Missing a simple phrase like acute on chronic or failing to link a cause and effect directly leads to immediate revenue loss and serious compliance risks. And this is exactly why experienced coders and CDI teams are your ultimate defense. They must issue precise concurrent queries while the patient is still in a bed. If a doctor casually writes respiratory failure, the CDI specialist has to jump in and ask, is it acute? Is it chronic? Both? Getting that clarification right then and there is the only way to ensure the chart is fully codable. Somatics matter everywhere in this system, guys. Even distinguishing between standard aftercare and active follow-up changes the codes. Aftercare means the active treatment is totally done and dusted. Follow-up implies you are still actively monitoring to make absolutely sure a severe condition doesn't rear its ugly head again. Now, here is a really fascinating scenario. We know that high-impact MCC conditions increase the DRG weight. But wait, what if a patient is admitted for a routine issue and then develops a severe complication during their stay? Does the hospital get paid more? The answer to that lies in present on admission, or POA indicators. Timing is everything. If that complication has a POA indicator of N, meaning it was not present on admission and is actually a hospital-acquired condition, it generally cannot be used to increase the DRG weight. This is exactly why distinguishing between pre-existing comorbidities and hospital-acquired complications is so heavily scrutinized by auditors. Let's wrap up our takeaways for this masterclass lesson. To succeed in the highly complex world of revenue cycle management, you really have to master both the macro GRG equation and the micro ICD-10 PCS definitions. Clinical similarity plus resource similarity equals your final DRG, but one precise MCC can completely elevate that claims tier. Meanwhile, procedural accuracy hinges on exact anatomy and root operations. And through it all, your clinical documentation improvement team remains your ultimate frontline defense against costly payer denials. Which leaves us with one final provocative thought. Are you passively reading charts, or are you actively investigating the clinical truth behind every single claim? Keep learning, keep querying, and never settle for vague documentation. Next time, in Part 111, we're tackling an advanced medical DRG deep dive into major diagnostic category 18, infectious and parasitic diseases and systemic infections. You won't want to miss it. Once again, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. I'll see you in the next one.